It gives me great pleasure to welcome Dr. Amit Chakravarthy to this BUSCON Symposium. We have selected a topic today which is very relevant, and we're going to speak on the newer aspects of OAB today. Dr. Chakravarthy is one of our own, graduating from the MKCG Bahrampur in 1980, went on to do his postgraduate from PGI Chandigarh, and then set his foot in England. He trained in Scotland for a few years and moved on to United States. There he graduated, completed his residency and also a uro-oncology fellowship. He went on to do wide range of diverse things, including the laser, the intestine, the female urology, but he became very well known in Indian soil for his workshop in PGI during the first ever live conference on pelvic health and pelvic floor reconstruction. I have also seen some of his work in vaginal mesh repair of the pelvis, and he's kind of great source of information to us. He's going to speak on OAB today. The other aspect that I would like to mention today is his very gifted singing ability. I was one of the mesmerized crowd in the Urology Society meeting, and he could mimic Muhammad Rafi, and is such a good singer, which almost parallels his professional career. So I welcome on board Dr. Amit Chakravarthy to give a talk on the subject.
Thank you, Kundu. Thank you very much, Vivasda, Dr. Kundu, and Dr. Gopal for giving me this opportunity. We wanted to be with you guys live, but because of COVID, couldn't make it live. But this is the second best thing. We have, in the last 2 years, learned how to survive. Last 3 years, actually, how to survive, and all of us have become masters of Zoom. So. If I could ask the videographer or the person who is running the presentation to put speaker view on, because right now I can see Dr. Kundu there. So if you can put speaker view, that'll be great. Can you do that before I start?
Just 1 minute, please. Let me try that. It's not something that I'm aware of.
Because right now, when you talk, when I talk, am I coming over as a speaker there? Because it might be happening in your end.
Yes, you are the speaker. We can see your slide in the foreground, and we can see you as a PIP.
Okay, so that's fine then, and that's okay. I'm not going to. Okay, that's perfectly fine. So let me get started. Okay. Thank you again. Let me get started on this topic, which is very near and dear to me. It's a newer treatment strategies in overactive bladder. We all know that overactive bladder is a very common malady. I am the director of the Center of Continence and Female Pelvic Health, and I'm also a faculty for a few medical colleges there. This is my disclosure. I am a proctor, researcher, and speaker for Boston Scientific, proctor for urologics, and researcher for Eurovant. So basically, the question today is to pee or not to pee. That's the question, paraphrasing Shakespeare. And there's a little thing which I always found very fascinating, and I start my talk with that. I called the incontinence hotline, and they asked me, could you hold, please? So what's the international ICS definition is that is defined as urgency with or without urge incontinence, usually with frequency and nocturia. So overactive bladder has to have urgency. Just frequency and nocturia does not constitute overactive bladder. So it affects over 33 million people in the United States, and the estimated economic cost in OAB in 2020 was over $20 billion in the United States. So that's how it is very, very important to be aware. So this is the prevalence, and 30% seek some care. Out of that, there are 55% of these people cannot tolerate the medication. And people who cannot tolerate the medication, out of them, about 70% seek further treatment because the medication either don't work or cannot tolerate it. These are the candidates of the newer modalities, which I'm going to talk about. A brief housekeeping thing. This is something which I don't have to belabor because everybody knows that. Bladder diary is a very essential tool because you want to know about the fluid intake. You want to know what they're drinking. If they're drinking a lot of, let's say, Pepsi, Coke, any caffeinated drinks, they will have overactive bladder. They may have urgency. And so that bladder diary is very important. Physical examination is very important, male or female, whether there's a prolapse, whether there is enlarged prostate, whether it's the frequencies because of the fact that they're not emptying the bladder completely. Urine analysis for infection and other abnormalities is very important. Because overactive bladder can happen due to bladder stones, as you know, or UTI. Some blood tests for kidney function. PVR measurement is very important because treatment, if you start them on medication, you need to be aware that make sure that this is not an overflow incontinence or incomplete bladder emptying. Pelvic ultrasound may help detect abnormalities. When you do stress tests, you ask the patient to cough, see if she's leaking to rule out any stress incontinence. Rarely we do some urodynamic testing. I know it's done much more common in India, but in USA there are specific guidelines. Only if the things don't add up, we do urodynamic study. Cystogram also sometimes to find out some abnormalities, reflux or prolapse. And cystoscopy is done if there is a associated hematuria or anything of that sort. So what is the first line of treatment? When we have a patient with overactive bladder, first we try to do behavioral treatment, like bladder retraining exercises. What do you do for bladder retraining? Delaying the event. For example, if you feel the urgency to go to the bathroom, try to squeeze your buttock muscles, perianal muscles, try to think of something else. Because if you run to the bathroom, try to beat your urgency, bladder usually wins. I tell them that let the urge go away and then you walk to the bathroom, you'll be more successful. Double voiding also sometimes helps. You go to the bathroom and go again. That helps to empty your bladder better. Toilet timetable is a very a nice way to prevent urgency incontinence, because if you see the patient is usually leaking when the bladder capacity gets to about 200 or 250, you tell them to actually have a time void, not wait till the bladder tells you to go, but go and empty your bladder before it actually hits you. Pelvic floor exercises have been used, not very successful, but still it's a part of the treatment course. Medications. We know that there are multiple medications. It used to be anticholinergics or antimuscarinics. And antimuscarinics have a lot of side effects and drop-off rate is very high. And recently we have some beta-3 agonists. These are sympathomimetics. And these are something which work the other way. As you know, parasympathetic tries to empty, sympathetic tries to store, as we know, all of us, about the autonomic nervous system. So anticholinergic medications do the same thing as sympathomimetics. So sympathomimetics are beta-3 agonists because bladder has beta-3 receptors. And the first drug which came out was mirabegron, which is marketed in the United States as Myrbetriq. It's been out for about 3 years. Great advance because there's no side effects of dry mouth, the blurred vision, constipation, etc. There's hardly any side effects really, except for slight bump in blood pressure, which is not clinically significant. Myrbetriq initially was expensive. I don't know whether it's still available. It's available in India or not. Then we have recently started. We have what's called Vibregron. This is a medication which has come far ahead of mirabegron and is just out since January of last year. I was a part of the study, and I'm going to show you about that. This medication has no drug interaction and minimal side effects. 75 milligrams, no titration of doses required, and this is going to hit the go for a 6. Tropical estrogen can be used to improve the pelvic, the mucosa of the vaginal mucosa and and sometimes helps in incontinence. Imipramine, tofranil has been used basically not related incontinence. We don't use it for overactive bladder very much. These are the 3 research studies which I was involved in, one of the 40 centers in the whole world. Based on these studies, this first and second study, this Vibergon got approved by FDA. Right now, I'm still doing this study, ongoing study on patients. We did the first study on any overactive bladder. Now we are doing the study on patients who have BPH and overactive bladder. So I'm still enrolling patients on that study. So we know the medications are great, but it has got a great discontinuation effect. And we very frequently, the patients do not continue on the medications. And that's where we get stumped. So a lot of younger patients especially don't like to take the medication, and the side effects quite significant, and they rather leak and not take the medication. So what do we have? We have got posterior tibial nerve stimulation. It is something which bridges the gap between conservative treatment, the medical treatment, and surgical treatments. It's an option when conservative methods fail, less invasive, less costly than surgery. It's an office-based neuromodulation and develops, and it is called posterior tibial nerve stimulation. It is almost like, so like here it is, this is the treatment algorithm. We try conservative therapy, behavioral techniques, diet modification. I forgot to tell you also that we also tell them to cut back on fluid and caffeine, and some local treatment like estrogen we talked about. Then we go to pharmacotherapy, antimuscarinics or anticholinergics, and recently beta-3 agonists. Now, if these don't work or the patient cannot tolerate it or it's too expensive, then they go for PTNS, and I'll go for the other things. So who are the people who are potential PTNS candidates? Insufficient response, intolerable side effects, unwilling to take drugs, unwilling to have surgery, unable to have surgery, unable to take drugs, or unresponsive to drugs. These are the people who actually are candidates for neuromodulation. There are 2, initially the studies were done. This is about, I think, 20 years ago. I started doing it almost 20 or even more than that, maybe 20, almost 20 years ago, I started doing this. Uroplasty was the company which developed this, called Urgent PC. It's got 2 components. One is a stimulator, which is reusable, and lead set, which is disposable. This is an office-based treatment. I call it a spa treatment. Patient is clothed, fully comfortable. Staff actually puts a little needle in the post. It's a very small, tiny needle. The patient cannot even feel the needle going in. It's like 34 French, a 34 gauge needle, and it's right next to the posterior tibial nerve, and the patient will tell you about the sensation. And you ask, and usually my nurses do it. I don't even have to do it, and the patient sits there for half an hour, and I call it a spa treatment. So this is the modulator. You see that this is the lead set. This part is disposable. This part is non-disposable. Actually, I have got about 3 of these urgent PCs. Don't use those because I've switched over to Mirbetric, to Medtronic system. But I'll talk to you more about that later on. So what happened was, and this is something which happens to people, like parasites take it over. All the studies were done by Urgent PC, but after a successful run of about 15 years, Medtronic, which is much bigger company than this Uroplasty company, came up with their own device. They tried to buy the other ones out. When they didn't sell, they came up with their own device called Neurosystem. Same principle, same everything, but it's called Neurosystem. How does it work? Well, the FDA approved 12 weekly treatments. You do it once a week, and then if you have a response, then you go monthly for 11 more months. So, so that is what the initial treatment and the sustenance treatment. Contraindications are patients who are pregnant or planning to become pregnant. There is only because no studies have been done for them. There have been no side effects or anything like that. We have not done studies on pregnant women, and they just thought that might as well not deal with that. Patients who have pacemakers or implantable defibrillators, patients who are prone to excessive bleeding or nerve damage that could impact posterior tibial nerve. For example, if you've got a diabetic neuropathy and that nerve doesn't really work, that won't work. So the risks are very low: transient moderate pain, inflammation, very mild bleeding. I've never seen any of these side effects in my patients. Advantages: it's up to 80% of patients response. We have got 20, 30 years of clinical history. This is an old slide, about 50 or plus or even more publications. And there has been random controlled studies, trials comparing urgent PC to sham and urgent PC to drug therapy, Detrol. And what's very important is that patients love it and they continue therapy even after the year is over, and it's very low cost and it's much less costly than obviously Interstim, which I'm going to talk about. It's office-based. You can start and stop sessions, minimal side effects, and it's covered by Medicare and other insurance companies. And like I said, these are all studies which showed great response rates from 60 to 80%. Then they did this Orbit study, which was urgent PC versus Zetrol LA, and it's a primary outcomes was frequency of voice. Secondary outcome measures were urgent incontinence, voided volume, overactive quality of life, and side effects. And they realized that this is non-inferiority complex. So they realized that urgent PC and drug therapy are equivalent, if not better, as you can see in this slide. And even after 12 weeks, they still compare same. You can ask the patient or the physician, and it's actually better than overactive bladder drug, 80% versus 55 and 60%. Constipation is much less often. Dry mouth is actually very, very rare with PTNS, obviously. Very small percentage of people reported some pain, discomfort, or redness of the ankle. And responders continued the treatment and continued to have sustained improvement even after 12 months. And these are baseline and these are 12 months data. So PTNS is a great thing to have, and this can be done in the office, very easily done. More importantly, is extremely cost effective and not very expensive. And I'm very surprised that it has not taken off in India. So next is Interstim therapy. So Interstim therapy is basically, it is this PTNS on steroids, I call it. PTNS, you actually stimulate the nerve, which root value is S3. S3 root value. So when you stimulate it peripherally, it goes and stimulates the S3. What is S3? S3 nerve controls the bladder and the bowel. So what Interstim does, it actually attacks the S3 nerve directly through the sacrum, and it utilizes mild electric pulses to the nerves associated with voiding function and also bowel function, because Interstim therapy also has been FDA approved for controlling bowel incontinence also, in addition to, but what's very interesting with Interstim can control overactive bladder, underactive bladder, and bowel incontinence. So I call it basically a pacemaker and a defibrillator for the bladder. Mechanism of action, we think that it actually it's both a sensory and a motor response. And there are theories of how it works by stimulating the S3 nerves, because most important to remember, it regulates the S3 nerve because it also works for non-obstructive incomplete bladder emptying. So clinical efficacy, great. 45% remain completely dry, 34% experience more than 50% reduction in leaking episodes. Remember, these studies were done on people who had failed all other treatment modalities, and these are the people who are very tough to treat people. And in fact, so people, it has been used for urgent incontinence, urinary urgency and frequency, also in retention, and it actually, in 61%, it eliminated the use of catheters. So like I said, it's used for overactive bladder and urinary retention. So, and also what's more important, the effect, once you put the InterStim and it's working, it sustains over time. There's a 36 months data where we see that 67% remain almost dry, 57 remain completely dry. So these are the things which are very, very important, that it sustains its efficacy over time. And this is proven by several case studies, case reports, randomized controlled trials, and there are at least 34 clinical trials in the initial phases of InterStim, which showed it was very effective, based on which FDA approved it. So clinical safety, the adverse ranking of adverse events in the first 12 months is pain at the neurostimulator site, some new pain, suspected lead migration, infection, transient electric shock. I had one patient of mine who said every time she went to the checkout desk at Walmart, she used to get a transient electric shock, and I had to actually take it out. Suspected lead migration happens if the patient's working great and suddenly she had a fall, and then suddenly it stopped working. That's something which you can, suspect lead migration. Pain at the lead side or pain at the battery side. Sometimes the battery can be a little superficial, and that may irritate the patient, especially when she's lying down. But the side effects are not that, if that happens, you can always revise it. The cost consideration, and this is a slide for here, so I'm going to just pass over, but what it just shows that if you consider the long-term diaper and medication costs, InterStim, though it's initially expensive, the cost over time, it evens out. So quality of life is great. They have shown a 10 to 40% improvement in depression scores. And that is why it's a great thing to have as a part of your armamentarium. I know it's a little expensive, that's why it's not caught on in India. So how do you do? Initial screening, voiding diary, urodynamic workup, do the behavioral techniques, medication. If it works, continue. If it doesn't work, do a basic evaluation. And if it works, go for. So basic evaluation is a test. We don't go and straight away put InterStim. And I'll show you in the further slide that we first do a test, which is done in the office. Initially, it was called a test stimulation. Now it's called basic evaluation. Just do the test, give the patient an external stimulator. So before the actual implant, we don't put the actual implant. We put a temporary lead onto the sacral tree and give them an external stimulator. Okay, and then now the external stimulator looks much better. It looks like a cell phone, a Samsung cell phone. So this is the brand new, and I'll come to that in a subsequent slide. So we implant the lead, and then the patient continues to do a voiding log. So pre-implantation, post-implantation voiding log. If we see a 50% improvement in the voiding, then we feel that that patient will actually benefit from this. And then we go ahead and put the real InterStim, which includes leads, which are much more difficult to come out. These leads come out very easily. It's because if it doesn't work, we just take it out in the office and we'll tell them that, hey, sorry, it didn't work. If it didn't work, then we can do what's called a stage 1 or an advanced evaluation, where we do the lead implantation under fluoroscopy in the OR. So let me get it straight. Basic evaluation is stage 1. This is how we do it right here in the office, and we'll just check. And how do you know that we are in the right spot? We see bellowing of the anal bellowing. Bellowing means it just flattens out. You'll see it beautifully if the patient has a nice response. And also toe flexion, great toe flexion. So these are the two signs we know that we are at the right S3 level, is toe flexion and bellowing of the perianal region. Once that happens, we know that it's going to be great. We also ask for sensory input, sometimes in the office, because we cannot crank up the power too much because it'll hurt the patient, we all sometimes ask for sensory. We ask them that, do you feel a vibration or vibratory sensation in the vaginal or the scrotal region? Do you feel a tapping sensation? That is another sign that we have got at the right spot. Once we have the right spot, we leave the temporary lead and give them an external battery. And they do a voiding lock, they come back, and if it is great, we go ahead and implant the real thing. If it is not, and the implantation is done, and the battery is kept put in the buttock in a pocket, and the leads this time are tined leads. Tined leads means it's like arrows, bunch of arrows, so it doesn't come out easily. So that's called a tined leads. Okay, so but if the patient did not work, and there is no other things they can do. In other words, you tried the basic evaluation or test him and it did not work. You can give them an option that, okay, this was blind, but we can do it under fluoroscopy in the hospital, in the OR. And this time we put the real lead so that if it works, we just have to put the battery. We don't have to do anything else. So that's called advanced evaluation. We used to call it stage 1, and just putting the battery was called stage 2. So initially we used to call it test him, stage 1, stage 2, or complete. Now we call it basic evaluation, advanced evaluation, and complete. So patient selection, who are the people who benefit the most? Patients who are younger and patients who did not wait too long. So that is the real thing which I now lecture to people, that you should not wait till the patient, till it's too late. You should go for it. If the medications don't work, don't fool around, just go for the InterStim. So younger patient, test stimulation performed within 4 years, and if there is evidence of pelvic muscle flow activity. Now, if there is some reason the pelvic muscle flow activity is weak, then it won't work. So now there's a recent study in 2015, which they have done. We always had kept InterStim for the ward patients who have leaking 5 pads a day, 10 pads a day. The bad leakers, we used to do them. Now we have evidence to prove that you don't have to wait till the symptoms get that bad. Even milder symptoms, patients are more satisfied if you give them this option earlier, because it's more efficacious and has no side effects of medication. This is the June 2nd, 2012. I did the international live workshop of InterStim at Ram Manohar Lohia Hospital in Delhi. You can recognize this gentleman. This is Dr. NP Gupta. Now what is the recent advances of InterStim, hot off the press? The only problem with InterStim in the past was people who, because it had metal, these people could not have MRI of the pelvis, of the lower extremity. They could have MRI of the brain, but not of the lower extremity. Now they have come up very recently, maybe last year, come up with MRI compliant device. And what's more important, the InterStim battery has to be changed every 5 to 7 years, because every battery, just like a pacemaker battery, it's exactly same company which makes it a pacemaker to the heart. So same type of battery has to be changed. Well, guess what? They've come up with a rechargeable device, which is micro. It's a very, very tiny battery. Patients do not even feel it. And it's great for younger people who don't like a bulging battery there. It's very tiny. It's tinier than a small key ring, and you can recharge it. It charges very rapidly. Once a week, you just wear a belt, just like charging your Tesla, you just recharge it. And lastly, intravesical Botox therapy. Botox is something which has people who have overactive bladder, people who have neurogenic bladder, especially multiple sclerosis and stuff like that. Those people have varying overactive bladder symptoms, and InterStim is relatively contraindicated on those patients. So those patients are very good for Botox injection. Botox, which we used for urology, is type A. There are 6 serotypes of Botox. Type A and type B are available commercially. Type A is used for bladder. Type B is used for muscle, torticollis and stuff like that. So how does it work? It works by inhibiting the calcium-mediated release of acetylcholine vesicles at the presynaptic neuromuscular junction in peripheral nerve endings, and it results in temporary flaccid muscle paralysis. I'm not going to go into details of mechanism of action because we are here to see what it does for us. What is the indications? 2 indications: refractory idiopathic overactive bladder. That means you've got an overactive bladder, medications don't work, and you cannot afford or don't want the Intravesicle or Ptns, or it didn't work. This is something for them. Or neurogenic overactive bladder, very, very effective in that. So those are the 2 indications. FDA guidelines says for the neurogenic overactive bladder, you use 200 international units. For idiopathic overactive bladder, you use 100 international units. Usually we dilute it so that it's 10 units per ml, and we inject 30 injection sites. And we usually spare the trigone. So we don't inject the trigone, and we inject it with a flexible or rigid cystoscope with the local. I do it in the local in the office, just instill 2%, 50 cc or 2% Xalocaine in the bladder and wait for about half an hour and inject it myself. So though there is no optimal dose, is still under investigation, but they tried using higher doses of people who have neurogenic diffuser overactivity, and they realized that there is no significant benefit of a higher dose. So this is the sites which we inject through cystoscope, and the most common side effects are urinary tract infection, 18% versus 6% with placebo, painful or difficult urination, 9% versus 7% with placebo. And this is the most important: temporary inability to empty your bladder, which may require self-catheterization. So for this, it is 6% to 0% for idiopathic diffuser overactivity. And I have to put that extra point in. For neurogenic overactive bladder, it is up to 20%. But these people are so grateful that they don't mind self-catheterizing. So neurogenic overactive bladder, because you're using a higher dose, the chance of retention is a little bit higher. So your contraindication is that if you have UTI, of course, you shouldn't do it. But you should always counsel the patient that there's a chance that this may work too good and you cannot empty your bladder. It's temporary, but till that time, you'll be willing to self-catheterize. That's more important. Botox, as all of us knows, that you have to re-inject in 3 to 6 months. You have to go ahead and re-inject because Botox wears off. I've had Botox last up to 9 months, but 9 to 12 months, you got to go and re-inject it. And it works as good. I did 2 studies on Botox. Also, my research studies, 2 or 3. One of them actually was efficacy of the Botox, 2nd injection and 3rd injection. That's a part of my research project also. So again, there's a black box warning. FDA puts a black box warning. I've never seen this happen, but sometimes Botox can get leaked into the general system, and you may have problems swallowing, speaking, breathing, and spread of toxin effects. Have never happened to me, and so that's basically it. So overactive bladder is a prevalent disease that increases with age. It impacts comorbidities and quality of life. Overactive bladder symptoms can be treated, but you should base more on symptom and syndrome-based treatment. What is happening to the patient? Let's try with that. The patient has constipation. You should try to give them a beta-3 agonist rather than antimuscarinic agent. And everything should be individualized to match the patient's preference. If the patient says that, hey, I don't like to take medications, can we try the Ptns? Yeah, go for it. Don't wait till the patient finishes 3 or 4 courses of medication and then try this. Then you obviously have to tell them that they cannot drink a whole gallon of iced tea or Coke, Pepsi, caffeinated drinks, or 10 cups of tea a day and expect the Intravesicle or any medication to work. They have to change their lifestyle and behavioral techniques, like I mentioned to you earlier, time void and bladder retraining. We know that medications sometimes work, but most importantly, it causes side effects, and a lot of time it doesn't work, and a lot of patients come off medications. And these patients, if they come off medications, it's not going to help us. So you need to find out that if these medications don't work, very quickly move on to the highly efficacious and tolerable minimal invasive therapies that I talked about. I'll be, whenever a patient comes to me, I usually ask them, root knock. I don't know if it was a live thing, I would have asked the audience, but because it's not live, I'll spell it out for you. It says, are you P-N-O-K? That's my car. And the urologist's favorite keyboard shortcut is Control P. Thank you.
Thank you very much, Dr. Chakravarthy, for the newer treatment strategies that are possible. I think we have moved much far beyond medications. One question I wanted to ask you before Dr. Kundu takes over is, you mentioned about Vibragon. Is that now commercially available in US?
Yes, Vibragon is called Gemtesa, Gemtesa is the trade name. It's available, and it's been available since last year, mid last year. Problem is that, as for any new drug, insurance companies are a little slow to catch up to start paying, so it's a little bit more expensive. So that is the only limiting factor. But it happens with every new drug. Whenever a new drug comes, it takes a little time for Medicare and other insurance companies start paying for it.
And in terms of Botox, obviously does not work in certain bladder diseases or if there is fibrosis. Is a bladder biopsy mandatory before Botox injection?
No,
To see
I don't know that. I don't do that. My main thing is that fibrosis usually happens is mostly in long-term, males with BPH symptoms. Okay, so those are the people who Botox. I use mostly I use Botox for people who have neurogenic bladder, especially females with neurogenic bladder, multiple sclerosis, etc. Those patients, it works great. Other patients I use Ptns are interesting because I have the ability to have all the three. But if a patient has a prostate and he's not had a TURP and it's an elderly male and you're going to inject Botox, it either might not work or it may put him into retention. But I don't do any biopsies.
Thank you. I leave it to Dr. Kundu to take over.
Thank you, Gopal. Thank you, Amit. Excellent talk and very comprehensive. Just a quick question and a real-life practical question. We in India, we practice with drugs alone, and for decades, for no reason. I don't understand why we have not taken the newer therapies. Now you have got a plethora of therapies available for you. How do you choose in the real world? If you have a patient who is refractory, now how do you define refractory? Because now that we have got a Myra background, we do not have the fallout of medicine that often. So if the patient is responding, fine. If they're not responding, how do you choose between a Ptns or an Intravesicle or which two? I mean, I realize that from your last answer that you use Botox more in neurological bladder, which is absolutely perfect with the science. But how do you choose between the Ptns? Looks very appealing to me. So how do you in real life segregate this patient into procedures? How?
That's a very, very, very good question. I'm actually guilty before this study came out, and this is only one study which I showed about Intravesicle for earlier cases. See, Intravesicle is a little bit more invasive. Till this MRI compliant device came out, till this rechargeable device came out, it was a big deal for the patients to go to the hospital and get the Intravesicle done. So the patients who have just minor symptom, minimal symptoms, not much of urgent incontinence, frequency urgency is what's bothering them, and they don't mind traveling. So sometimes it depends. Is coming from 50 miles away and she has to come every week for 12 weeks. That may be a limiting factor. So various things comes into play. The severity of the incontinence, the patient's compliance, whether she or he can drive and come and stay there and get this treatment done, and the insurance coverage. All of them make a difference. Some people, insurance doesn't cover Ptns, so we have Intravesicle, we have to go to Ptns. So in USA, that is one factor. But in India, where you do not have, Intravesicle is so expensive. I think you guys should think about going for this PTNS treatment. And what I could do, and this is kind of off the record, you can snip it off later on. I've got 3 urgent PC, which I don't use anymore. I can bring those machines and kind of donate one of those machines to Kolkata Bengal Urological Service so that you guys can at least get started. You know.
That is a very good suggestion. Gopal, I think we should take on board and start a small mini trial within ourselves. But the other question that pops up, and I know we have very limited time now that we are overrunning, in terms of efficacy scale, I mean, you're comfortable exchanging a PTNS with the Interstim or a Botox? I mean, is the efficacy level the same, or you have more faith in a particular newer therapy?
Again, if the patient has bad incontinence, I don't go for PTNS because I believe, though the authors will not, if the patient has a 5 pad a day bad incontinence, I go for Interstim. I don't go with PTNS because PTNS also, even if it is efficacious, remember, they have to work for it for 12 weeks. Interstim, you put it, next day they are dry. So that is, or Botox also for that matter, it's very immediate effect. PTNS for a very bad leaker, she may not have the patience to pursue the treatment course. That's the reason I guide patients with bad incontinences who fail drug therapy or cannot tolerate drug therapy. I guide them to Interstim. Minor patients who feel that Interstim is a big deal, especially when it was not MRI compliant and they have to carry something and have that changed every 5 to 7 years, those are the patients I used to veer towards the PTNS treatment, especially older patients, especially if they have somebody to drive them here. Older patients are great. They come over here, they've got nothing else to do. They'll sit in the office, read a book, and they get the PTNS treatment, talk to my nurse, chat, share the family stories. It's almost like a therapy right there.
Oh, that is what exactly I was looking at. I mean, in India, we would welcome the Vibregone. We would try with medicine as much as it would go because of the other risk factors. And the next step would be, if it is a severe incontinence, probably take up Interstim. Gopal, I think we are well out of time. So we'll wind up with a very good thank you to Amit for a wonderful, excellent, comprehensive discussion on the subject. Thank you.
Thank you very much to both of you. Thank you.
Thank you so much for having me. And I look forward